I'd like now to ask our speakers to come for the session of questions and answer. Dr. Al-Hashim, Dr. Allison, Dr. Volpicilli.
Question for Dr. Allison. Now, when you mentioned the delay in time when using ultrasound for resuscitation or to find out the standstill heart, was the delay because it was difficult to get a view, or was the delay because they needed some more time to evaluate the standstill?
So it's both, and I can tell you just because I reviewed the videos that most of the time the probe wasn't in position, so the chest compressions would stop and it could take a second to get a view, or it could vary to 10 seconds to get a view. It's hard from the video to determine whether there was an adequate image on the screen and if they were actually interpreting it, so that's a limitation of the video-based review. So it's hard to know whether the interpretation time was long, but certainly it did seem like, looking at the videos, it took time to get the actual image. But again, without seeing the monitor screen, it's hard to quantify that in a number, so we weren't able to look at the data on that.
Now, do you think the use of transesophageal echo, these small probes that would just give you the view, as you put the tube down to ventilate the patient, you put the probe as well, and you will have online monitoring of your chest compression, your views if you want to see?
I'm ready to use it tomorrow.
Okay.
I'm ready to use it tomorrow. If you give it to me, we should use it, yeah. And I think the thing is, I would think that the technology could be adapted. We'd have to study it. We'd have to see if it actually makes sense or if it's going to be an inappropriate use of resources. But certainly you can get the views. You would, in order to perfectly interpret the still heart, you'd still have to stop the compressions.
Yeah.
But you can acquire the image beforehand, and you can interpret the image very quickly, so you'll minimize chest compressions. And then the TEE could also be used to monitor compression depth fraction, and I think there's some applications for while compressions are being done using TEE to monitor. So yeah, I think TEE is probably going to be the way to go, but I think there's a big curve to get it into emergency departments, into the ICU, and getting people trained on it.
Okay, thank you.
I just have a little comment on tamponade, cardiac tamponade, and what do you do as a emergency physician or a physician or any doctors in the ER. Just as an advice, tamponade easily can be diagnosed if you are trained well and you know what you're looking for. Don't wait for the cardiologist. Okay, the case I showed you in the tamponade, the patient was arrested. And basically, I remember he didn't survive after that because he was ventilated for 6 hours until I saw him the next morning. So remember that echo can be done very easily. Okay, it is the basics of echo are very, very, very simple. I can teach non-medical physicians for that. Okay, but the complex where it comes to diastolic function and other stuff, that's where we're supposed to be there. I mean, as a cardiologist, I'll be very happy to sit in the echo lab and do stuff that comes as an OPD level. But in true life, in emergency and in critical care, you need to start to hold the probe and start to dig things over. Because easily, we saw a lot of cases who have low ejection fraction, low BP, and we do the echo for them. We change the inotropes. We managed to assess the diastolic function, and we decrease the inotropes, and the blood pressure go back up again. I think the reason for that we sometimes we overuse our inotropes that will depress our LV ejection fraction. There will be a lot of things to be learned, but they are very basic, they are very simple. Medical students could learn them, to be honest. So I think the message from this session is just to hold the probe and do some basic training, and believe me, you'll do a lot of difference in your practice. Thank you for your comment.
Thank you very much for those lectures. Would you advocate really adding ultrasound and echography studies into the medical schools? I think it is quite difficult for somebody probably in the medical field again to go back to him. It's really becoming like such a simple tool now. It's probably going to end up like on daily use from now on, and I think maybe it should be incorporated into the medical school itself, that learning, at least the basic physics behind it. What do you think about that? Is there an NH medical school which teaches those tools?
So you mean, if I well understood your question, the problem of introducing ultrasound teaching in the school?
We learned using stethoscope at the medical school. The reality is that now maybe ultrasonography should be added as a part of the teaching in the basic medical schools.
Of course, it should be part of the very basic teaching in medicine. Speaking about lung ultrasound, again, lung ultrasound is a very basic application of ultrasound. It is strange to say because lung ultrasound is a very modern application because it came out in the last 10-15 years. But it is a very basic application. What I always tell to my students is that if you want to start using ultrasound, please start from the lung examination, because the lung examination will give to you the very basic of ultrasound use. And then you go to other more complicated organs like the cardiac ultrasound. So if your question is if ultrasound in general should be introduced in the School of Medicine, my answer is of course yes, and it will happen very soon.
And I'll comment on that briefly. I think, yes, of course, it should be integrated. If you think of the number of specialties that are using point-of-care ultrasound, we encompass, one general specialty of those involved in resuscitation of patients. Surgeons with FAST we can include in that. Obstetrics and gynecology are using it. Endocrinologists are using it for thyroid. So I think the physics, the underpinnings, the information needed to advance through whatever specialty you choose is very important to learn. I think we should put it into medical school curriculums. In the United States, it's already made it into, but there's still a lot of work to do.
I totally agree with that point. I think it's better for medical physicians to start using practical stuff, ultrasounds, echoes, instead of wasting their time learning about plants, zoology, and other like basic medical science that will not help you during your medical practice. Okay, to be honest, this is a frank point. I waste my time learning this stuff. Then when I go to real clinical practice, I find the doctor is a kind of a supervisor. Okay, do this, do that. Instead, the doctor he's the person should be doing stuff. Okay, I think yes, it will need a lot of change. And I think the best stage for that is that during the internship and they start the residency. That's the very best. Instead of starting straight away, you should train them like 1 week for some medical instrumentations or whatever, like an introduction, before they start their residency, and it should be implemented in the residency program. That is the best. Was my opinion.
You asked a very biased group on that question. Of course, you're going to get yeses.
I think the future will be an anesthetist or a doctor, instead of carrying a stethoscope around his neck, the future will be a portable echo ultrasound in his pocket. And I think mobile phones, smartphones, I think that's the future. I mean, I learned doing central lines using landmarks, but that's became a history now. And I think medical school probably should integrate those systems now. They are becoming basic tools with all specialties are using it. It's not really, we used to think cardiologists are the ones only do echo, where now actually everybody should be really able to do it maybe, in the future anyway. Thanks.
Actually, some doctors, they don't use their stethoscope. Okay, so and you start them to use the ultrasound probe.
Anyway, I must compliment the organizers of this conference, because it is not common to have so much space about ultrasound in anesthesia conferences in the world. So this will change in the future. What we are trying to obtain is to include, by doing research, of course, and getting very, very good results and with a lot of data, is to be included, ultrasound use, I mean, in the main societal guidelines. That is the next step. Then, once we will be included in the societal guidelines, everything will come, everything, of course. But the first step, in my opinion, at this stage, is to work to obtain data, demonstration, and to be then included in the societal guideline. That is a very hard work. And not because it is difficult to obtain data, because it is very difficult to change the mind of people. This is very difficult, I find. We have, for example, speaking about chest X-ray and lung ultrasound. For instance, in pneumothorax, we have a lot of data about the usefulness of lung ultrasound in pneumothorax now, because we have many studies published. But still, there is a resistance considering lung ultrasound useful for pneumothorax. Why? Because there is chest X-ray. But if you go to look how many data have been collected about chest X-ray in pneumothorax, I tell you that there are 0 studies. So it is a convention, and it is very difficult to break this convention, but it will happen in the future.
Any further questions? No? Okay, I think we'll close this session for now.